Hi, my name is Rachel Sage McCafferty, and I'm going to be demonstrating a mental status exam as well as a neurological, cardiovascular, peripheral vascular, neurovascular, respiratory, and abdominal assessments today. The very first thing that I would do would be to check my orders. After that, I would gather my supplies. I have a stethoscope here that I'm going to use for auscultating. I have oil of lavender that I'm going to use to test or to assess the patency of the nose. I have a cotton ball that I'm going to use to assess the sensation of light touch. I have a pencil here that I'm going to use to assess sharp pain versus dull pain. I have a pen light here that I'm going to use to assess the eyes. I have a very dull knife that I'm going to be using the end of to assess the patellar and plantar reflexes. And lastly, I have PPE. I have gloves because I will be putting my hands on the patient. And I have an ice pack here as well to assess whether or not they can discriminate temperature. Okay, I will get started. I am going to wash my hands as I'm going into the patient's room. I'm going to acknowledge the patient and introduce myself. Hi, my name is Sage. I'm going to be your nurse today. Then I'm going to pull the curtain to provide privacy. I'm going to then ID the patient. Can I please have your name and date of birth? Okay, I would double check that with his wrist bracelet, and it's correct. Then I'm going to explain the procedure and let him know that it's going to take approximately 30 minutes. After that, I will raise the bed, and then I will begin my assessment. So the very first thing that I'm going to be doing today is observing the general appearance of my patient. He appears to be clean and well-groomed. He is dressed appropriately for the weather. He is relaxed and his posture is erect. He is sitting up in bed. Then I will move on to the behavior of the patient. The patient seems to be calm and smiled appropriately whenever I introduced myself. The patient also is awake, alert, and aware of internal and external stimuli. And the patient also reacts appropriately to conversation. Next, I will assess judgment. Whenever given the building burning scenario, I will ask the patient, what would you do if your house caught on fire? That would assess judgment. Then for orientation, I would assess the patient's knowledge of time, place, person, and situation. For time, I'd ask generally, what time of day is it? Then for place, where are you right now? And for person, who's the president right now? And then situation, why are you here? Then I would assess memory. So at the very beginning of the assessment, I had given the patient 3 unrelated words to remember, and I will have him recall that for short-term memory. For long-term memory, I would ask the patient, when was your youngest brother born? Or when was your last hospitalization, something that I could verify. And then for immediate recall, I would ask the patient, repeat a phrase after me. All pigs go to heaven. And he should be able to immediately recall. Next is attention span. And I would give the patient a set of directions and note if there was any break in attention span. Then I would assess cognition. The patient is seeming to understand what I'm saying and is answering appropriately. And then speech, if the patient has regular, is clear and coherent and has a regular rate, rhythm, and tone. So that would be the mini mental status exam. And then next I would move into the 12 cranial nerves assessment. So the very first cranial nerve is the olfactory nerve, and so this would be assessing the patency of the nose. Before touching anything at this point, I have already washed my hands and not touched anything, but I'm going to go ahead and apply PPE. So for cranial nerve 1, olfactory, I'm going to have the patient close his eyes and cover one nostril and tell me what he smells. So I have the oil of lavender here. Sniff, and then he should be able to correctly identify the lavender, and then I'd ask him to plug the opposite nostril and then also assess the patency of that nostril as well. Then the second cranial nerve is the optic nerve, and I will be using a pin light to assess that. So I'm going to ask the patient to stare at a distant object. I'm going to put my hand in the middle of his face. Then I'm going to draw the light inward on both sides. And I'm assessing that the pupils are equal in size, which should be about 3 to 5 millimeters, that they are both round and that they react to light and that they accommodate the light. I would also, when I'm shining my pin light into their eye, I'm going to be looking at the back of their retina. For the red reflex, the back of the retina should be red, intact, and there shouldn't be any dark spots or any cloudiness, which would be indicative of disease. So after optic is oculomotor. I'm going to need that pin light again. So oculomotor is cranial nerve number 3. Cranial nerve number 4 is trochlear, and cranial nerve number 6 is abducens. And all of these cranial nerves control eye movement, so I can assess all 3 at the same time with the 6 cardinal gazes. So I'm going to have my pin light, and I'm going to ask the patient to keep his head completely still and just follow the pin light with his eyes. And I'm going to start by going up, then down, then right, then left, and then at 2 points diagonally. So that assesses cranial nerves 3, 4, and 6. Cranial nerve number 5 is trigeminal, and I will assess this by asking the patient to open and close his mouth and clench his jaw. So, and then after cranial nerve number 5, we've already done 6. Cranial nerve number 7 is facial. To assess the facial nerve, I will ask the patient to raise his eyebrows, to smile, to frown, to show his teeth. So that is assessing cranial nerve number 7, facial. Then cranial nerve number 8 is acoustic. And I will do this by using the whisper test. I'm going to ask the patient to cover one ear, and in the opposite ear that is uncovered, I'm going to whisper 3 words, and I'm going to try to do this by hiding my face behind the patient so he can't track my lip movement. So I will have him cover one ear, 1, 2, 3. And you should be able to hear that whisper, and then I'll do that in the opposite ear as well. That's the whisper test, and that is the acoustic nerve number 8. Cranial nerves 9 and 10 are glossopharyngeal and vagus. I'm going to assess these by having the patient say ah. Whenever he says ah, I will be able to track whether or not the soft palate rose and whether or not the uvula was midline and rose as well. After cranial nerve number 10 is cranial nerve number 11, the spinal accessory nerve, and I will assess this by having the patient shrug his shoulders, and I will place my hands on his shoulders and tell him not to let me press down. So that will assess cranial nerve number 11, and then cranial nerve number 12 is hypoglossal. And I will assess the cranial nerve number 12 by having the patient protrude their tongue and say light, tight, and dynamite. Light, height, dynamite. So that is all 12 cranial nerves. Then I will assess the patellar reflex, and I will demonstrate on myself. The patient should not have their foot touching the ground. They should be seated. And whenever the end of the hammer hits the area right below their kneecap, the leg should kick outwards. And if that occurs, then that would indicate a +2 rating. Next, I will assess the plantar reflex. And I will do this by also taking the end of the hammer, if I have one, and tracing the bottom of their foot from the heel to the pinky toe and then across to the big toe. And the patient's toes should curl inwards. If they do not and they fan instead, that is a positive Babinski sign. And there should only be a positive Babinski sign up to 6 months of age. So toes should curl inwards. After that, I will do the Romberg test and have the patient stand. And when the patient is standing with his eyes closed, he should be able to stand with his eyes closed without swaying or falling. And so whenever the patient does this in the Romberg test, I want to have my hands in front and behind him to be able to assist him to the floor if he were to lose his balance, or just to help him regain his balance. So that's the Romberg test. And then also I would assess coordination by having him do a heel to toe walk. And then whether or not he could do rapid movement. So I'd have him do this, or have him do opposing touch on his fingers for rapid movement. Okay, after that, we're going to move into cardiovascular. Okay, so for cardiovascular, I would first have the patient seated, and I'm only going to expose the areas that are necessary for the inspection and for the current assessment. Also, I want a good tangential light source so that I can properly inspect the areas that I'm assessing. So I would first start by noting that I don't see any deformities in the chest wall. Everything looks symmetrical. I'm not seeing any masses or nodules or any areas that have erythema. So the chest wall is looking really good and intact. I am not noting the apical impulse in my patient right now, but sometimes that can be visible. I'm also going to note that the right side of the heart is posterior. The right side of the heart is anterior, and the left side of the heart is posterior. Yes. And then the base of the heart is on the right sternal border, and the apex of the heart is at the 5th intercostal space of the midclavicular line. So that is the location of the heart. And next I'm going to move into auscultation. For the purpose of this video, I'm not going to have it in my ears because it makes it a little bit harder for me to hear what I'm saying. So the 5 areas that I'm going to listen to in the heart are the aortic, pulmonic, Erb's point, tricuspid and mitral areas. The aortic area is on the right side in the 2nd intercostal space. The pulmonic, and also in the aortic areas where you can hear S2 the best, that is the sound of the semilunar valves closing. Moving over to the pulmonic area, that is going to be in the left 2nd intercostal space. Then I will move down, and that is going to be Erb's point at the 3rd intercostal space on the left side. You can hear S1 and S2 at this area, and so you would be able to listen to them together. And then after Erb's point would be tricuspid, and tricuspid is going to be in that fourth intercostal space in the lower left. And then after tricuspid, I'm going to move over to the mitral, which is going to be in the fifth intercostal space at the midclavicular line. And so those, and then the mitral area is where you can hear S1 the best, and S1 is the sound of the atrioventricular valves closing. So whenever I'm listening to all of these heart sounds, I'm listening for extra heart sounds, which you don't want to hear. I'm listening for rate and rhythm, making sure that they are both within limits, and for the rate, that it is at an appropriate rate, and then for rhythm, making sure that there isn't any irregular beats. I'm also listening for heart murmur, and didn't indicate any of those with my patient right now. So after auscultating the heart, I'm going to move on to the peripheral pulse points. I'm going to palpate first the carotid artery. I want to make sure that whenever I'm palpating the carotid arteries, I'm only doing one at a time, as to not instigate a syncope. So carotid arteries, one at a time, and then brachial artery, radial artery, femoral artery, popliteal, dorsalis pedis, and then posterior tibial. And so whenever I'm palpating these pulse points, I'm going to be noting any pain. I'm going to be making sure that I can palpate the pulse points. Now, sometimes the popliteal pulse point behind your knee is really hard to find. So it is very important, though, also whenever you're palpating the carotid artery, that you are feeling for a bruit, which is a vibration or a thrilling sensation that you would feel if there was obstruction in that artery. So next, I'm going to assess for pain, pallor, paresthesia, and paralysis. The patient has been moving all of his limbs, and so I do not indicate any paralysis. And whenever I was palpating the pulse points, there were no indications of numbness, so no paresthesia. I'm going to assess with the patient now whether or not he can discriminate between sharp pain or dull pain. So with the tip of the pencil, that would be the sharp pain, and he should be able to tell me whether or not it's sharp, and then with the eraser, if it is a dull compared to the sharp. After that, I will assess for light touch. I'm going to ask, can you feel this? And he can feel it on all of his limbs. Then I'm going to assess for temperature. Can you tell me if this is hot or cold? And this is an ice pack. Hot or cold? He says cold. Okay. Next, I'm going to move on to respiratory. Before respiratory, I'm going to check for edema and capillary refill, which I would also, if I was doing a respiratory assessment, check for capillary refill. But for edema, I'm going to press my finger into his ankles, and there should be no pitting. Any pitting would be indicative of edema. And for capillary refill, I'm going to take his finger and press down on his nail bed, and it should blanch upon pressing down, but as soon as I release, it should return to its normal pink color within 1 or 2 seconds. So that's capillary refill. Next, we're going to move on to respiratory. Again, for respiratory, you want to make sure that only the areas that are absolutely necessary to be exposed are exposed. Whenever I'm assessing respiratory, I'm going to be checking anterior and posterior chest. I'm looking for any masses or lumps or deformities or making sure that he is inspiring. That's important. I'm noting the rate and the rhythm of his respirations. Right now, my patient is respiring at about 14 breaths per minute. Anywhere between 10 and 20 is okay. After inspecting, I'm going to go ahead and note with you guys that the right lung has 3 lobes, whereas the left lung only has 2 lobes, and this is due to the location of the heart. Also, my patient does not seem to be in a state of respiratory distress. He is relaxed, his nostrils aren't flaring, and he is alert. So next, I'm going to move into auscultation. Before auscultating, I'm going to continue my inspection by measuring the AP diameter, and I'll just use my stethoscope as a general line to measure this. And AP diameter is anterior-posterior diameter, or antero-posterior, and this should be at a 2-to-1 ratio. So this should be the 2, and then on the lateral side, it should be half of the length that it was in the front, indicating a 2-to-1 ratio for the AP diameter. Increased AP diameter would indicate barrel chest. The patient kind of has a barrel chest, but so next I'll auscultate. So with my stethoscope in, I'm going to be listening to 5 areas on the anterior chest, on both sides bilaterally. And I'm avoiding any bones, I'm avoiding any dense tissue such as breast tissue, because it would be really hard to hear the lungs over that type of tissue. So I am listening for any adventitious lung sounds. I'm listening for rales, crackles, wheezes, and I'm also making sure that he is making a full inspiration and a full expiration at every point that I'm listening to. And then I'd have him turn around or sit forward, and then I'd listen to his back. And on the back, I'm listening to 9 areas. That's going to be down each side, and then I'm also going to move laterally. So 1, and then I'm also spacing these about 5 centimeters apart on humans. So I'm listening over all lung tissue for an entire inspiration and expiration in each of these areas. After auscultating the lungs, I'm going to palpate. Well, I would have palpated before auscultating. I'm palpating for any areas of tenderness or masses, making sure there aren't any masses or nodules. Next, I'll continue with palpation by assessing for tactile fremitus. And for tactile fremitus, you're wanting to hear vibration because in decreased tactile fremitus, For example, somebody with emphysema would have decreased tactile firmness. You want to feel a vibration when you're palpating. And in order to feel this vibration, you're going to ask your patient to say either Blue Moon or 99 when you move your hands down their back. And you're going to do this in 5 areas again. And I'm going to tell my patient every time I move my hands, say 99. So in each area, 1, 2, 3, 4, 5. I was able to feel tactile firmness in all of those areas. After that, I'm going to check for equal chest expansion. So I'm going to put my hands on the patient's back and ask them to take a very deep inspiration, and my hands should move symmetrically. They should, if one moved and the other one didn't, that would be indicative of a collapsed lung, and we don't want that. So my hands should move equally. Next, we'll move on to abdominal. For abdominal, I'm going to place the patient in a supine position. And then have him, or I will bend his knees to give him a little bit more comfort, but also make things a little bit easier for me to palpate. So first, I'm looking at the contour of the belly. His belly is round. It appears soft. I don't see any masses or nodules or lumps. I don't see any scars. I don't see a hernia. I'm assessing there's no erythema on the abdomen. And after inspecting, auscultation always comes after inspection when you're doing an abdominal assessment, because you don't want to stimulate peristalsis. You want to be able to listen without stimulating any movement in the GI tract. So whenever I'm auscultating, I'm going to start in the right lower quadrant, because this is where the ileocecal valve is, and there are almost always vowel sounds present there. So I'm going to start in the right lower quadrant, then I'm going to move to the right upper quadrant, then I'm going to move to the left upper quadrant, and then the left lower quadrant. I'm going to listen for at least a minute in each quadrant to note whether or not the vowel sounds are hyperactive or hypoactive. A hyperactive vowel would have sounds that occur more than 30 times per minute, and then a hypoactive vowel would have sounds that occur less than 10 times per minute. So you want to be within the 10 to 30 sounds a minute range. But also, if you do not hear any vowel sounds, then you got to listen to each quadrant for 5 minutes before reporting to the physician that you cannot hear anything in his bowels. So after auscultating the abdomen, next I will move to palpation. So I'm going to start with light palpation, and then I'm going to do deep palpation. When I'm palpating the quadrants, I'm doing it in this fashion, not this, or not that, but I'm making sure that I'm moving my fingers over the quadrant, and I'm noting what's under there. In the right lower quadrant, we have our appendix and our cecum. Right lower. In our right upper quadrant, we have our liver and gallbladder. In our left upper quadrant, we have our stomach and our spleen. In our left lower quadrant, so the last was left upper quadrant, and then the next one is left lower quadrant. In the left lower quadrant, we have part of our descending colon and our sigmoid colon. So after palpation, I would do percussion. I'm gonna put my fingers like that and tap, and I should hear timpani or a hollow sound over hollow organs such as the stomach and the intestines. And I should hear dullness over dense organs such as the liver and the spleen. That wraps it up for our assessments, and the next thing that I would do would be to return the bed, I'm going to cover the patient back up. I'm going to return the bed to its normal height, which is to be all the way down. I'm going to make sure that if any bed rails are up that need to be up, they're only at most 3 bed rails up, because 4 rails is considered a restraint and that requires a doctor's order. So I'm going to return the bed. Then I'm going to assess for additional patient needs. Would you like to be sitting, or do you want to stay lying? He wants to stay, or he wants to sit. So I'm going to sit him back up. Is there anything else that I can get for you? He says no. So I'm going to make sure that he has his call light. I'm going to dispose of my PPE properly. I'm going to wash my hands. And then I'm going to document. Thank you so much for watching my video today, and thank you, Mr. Bear. All right, see you later.